Assalamu alaikum. This presentation is on Reinke's edema of the vocal folds, the demography, the etiology, the pathology, the clinical picture, and the management. Reinke's edema is a swelling of the vocal folds that is benign, diffuse, and sessile due to the excessive deposits of glycoproteins and hyaluronic acids in the superficial layer of the lamina propria. These deposits would stay in place in the vocal folds due to the poor lymphatic drainage of the vocal folds. It's bilateral in as much as 85% of the cases. It's fairly common, being the third most common disease affecting the vocal folds after vocal fold polyps and chronic laryngitis in one large series. A large meta-analysis had showed no difference in the rate of affection between males and females, with almost similar rates, but females are more likely to seek medical help because of the effect of lowering of the pitch on their voice. The usual age is between 40 and 60 years, but it can affect teenagers or the very elderly. The condition has many names. The first time the lesion was described in the American literature, it was called a smoker's larynx. But other names include things like chordal polyposis, polypoid chorditis, pseudomyxoma, pseudomyxomatous laryngitis, polypoid vocal fold, and polypoid vocal fold degeneration. Last name, the vocal folds polypoid degeneration, perhaps refer to a subset of Reinke's edema, of untreated and chronic Reinke's edema, in which some changes had happened over the time, including things like increased submucosal fibrosis, thickening of the epithelium, and some fluid absorption. This would lead to multiple lobes along the entire length of the vocal folds rather than one large diffuse and sessile swelling, which is the usual typical picture of early Reinke's edema. The exact etiology of the condition is yet to be identified, but it's known that it almost exclusively affects moderate to heavy smokers. Other contributing factors include vocal strain, laryngopharyngeal reflux, and it can be a concomitant feature in hypothyroidism. Klein-Sasser had noted that the accumulation of the fluid in the subepithelial space of the lamina propria can be the result of the changes in the microvessels permeability in the superficial part of the vocal fold. This was later also suggested with electron microscopic studies that had showed changes in the vessels of the submucosal lamina propria that may lead to the condition of Reinke's edema. The specific pathological features of Reinke's edema as accumulation of deposits in the subepithelial layer, these lakes of deposits in the superficial part of the lamina propria, and changes in the microcirculation of the subepithelial layer. This changes in the microvessels ranges between widening of these microvessels and also thickening of their walls. There may also be some extravasation of RBCs in the subepithelial layer, and in about half the cases there may be some inflammatory cells. The changes of the overlying epithelium are very nonspecific, apart from some thickening of the basement membrane, and occasionally hyperkeratosis due to the microtrauma, phonotrauma of the vocal folds that may give rise to white plaques over the surface of the vocal vocal fold, but no dysplastic features are usually seen. These specific pathological features were supported with the examination by electron microscopy of biopsies from Reinke's edema that showed loosening of the intercellular junctions and widening of the intercellular spaces in the subepithelial layer of the lamina propria. The characteristic feature remains wide microvessels in the subepithelial space, together with thickening of the walls of these vessels and increased permeability. The changes affecting the overlying epithelium are nonspecific. The epithelium may be thinned in part and thickened in others due to deposition of fibroelastin under the basement membrane. Patients with even severe Reinke's edema may not have any specific complaint and may not seek medical help. The most common symptoms are deepening of the pitch of the voice. And although this affects both males and females almost equally, the females would notice that their voice is now being mistaken for a man's voice, particularly over the phone. They may also be effortful speaking due to the need to increase the subglottic pressure to drive vocal folds oscillation. Sometimes there will be inability to raise the pitch of the voice and also some choking episodes in the severe cases. Also, patients may report symptoms of gastroesophageal reflux, which is a common association with Reinke's edema. The dysphonia in the Reinke's edema patient may be either to disruption of the mucosal wave or the effect of the deposits on the mass of the vocal folds. This would lead to lowering of the fundamental frequency down to perhaps 80 Hz in men and 110 or so in females. Some male singers may drop into vocal fry. Pain is a very unusual feature of Reinke's edema. In extreme cases, patients can describe dyspnea and even stridor, and there is a report of at least one patient who had tracheostomy due to the laryngeal obstruction by his advanced Reinke's edema. On laryngoscopy, the usual features are diffuse and sessile swelling of the vocal folds that can be asymmetrical and can be unilateral, but by far it's more common to be bilateral. The color of the vocal folds would be anywhere between grayish or yellowish, sometimes with a red hue if there is associated gastroesophageal reflux. The superficial blood vessels would be prominent, and sometimes there would be whitish patches over the vocal folds due usually to phonotrauma. Sometimes, although this is very uncommon, there would be dysplastic changes, and there have been few reports of carcinoma in situ as well. The usual feature on stroboscopy is a large mucosal wave and large vibratory amplitude. This implies that the viscosity of the mass deposits is quite low. This would support the diagnosis of Reinke's edema over other conditions increasing the mass of the vocal folds, in which increase in the stiffness is expected. The lesions can be seen to flip in and out of the airway. If the material becomes very thick and tenacious, the mass effect would show as a rocketing on top of the vocal ligament. The most common feature on voice analysis would be a significant drop on the fundamental frequency in both females and in males. In early cases, the subglottic pressure may remain nearly normal, but with increased deposition and increased mass of the vocal folds, the pressure required to drive the vocal fold oscillation would need to be increased, and patients may complain from voice fatigue. This voice fatigue may be the primary reason for consultation and seeking treatment for these patients. In cases of unilateral Reinke's edema or asymmetrical Reinke's edema, there will be a greater vibratory amplitude and greater mucosal wave of the affected side. There will also be a slight increase initially in the subglottic pressure due to the need to increase the pressure to drive oscillation. The asymmetry of the vocal folds vibrations can be noticed, and sometimes this can lead to a disturbance in the periodicity. These disturbance in the periodicity can give rise to breaks due to the breakdown of the vocal fold oscillation. Several grading systems were suggested to grade the severity of Reinke's edema, mostly based on the size of the lesion. This real size of the lesion would be better judged during inspiration rather than during phonation. During phonation, the size can be underestimated as the lesion would tend to flip up and down the vocal folds or laterally towards the laryngeal ventricle. One of the common grading system grades the severity into 4 stages. Stage 1 would only show marginal edema of the vocal folds, but on stroboscopy there would be a large amplitude of the mucosal wave. Stage 2 would show a sessile, clearly obvious sessile swelling of the vocal folds that is thrown over the vocalis muscle during phonation and have irregular mucosal waves on stroboscopy. Stage number 3 would have a large bag-like swelling filled with fluid, and the epithelial wave is difficult to recognize and have irregular amplitudes. The final stage, stage 4, would be characterized by partial obstruction of the airway because the medial borders of the vocal folds are now in contact along most of the airway. This can lead to dyspnea during exercise. The stroboscopic features are similar to grade 3, in which there is difficulty in recognizing the mucosal wave and irregular amplitudes. Another grading system is based on the extent of contact between the medial borders of the vocal fold. If it is less than 25%, it's grade 1. Between 25 and 50% of the airway, it's grade 2. 50 to 75, it is grade 3. And more than 75% of the airway showing medial contact of the two sides would be grade 4. Early and mild cases can be managed without the need for surgery by stopping smoking and voice therapy. Surgery should be considered in some occasions, including gross Reinke's edema causing choking sensation or airway compromise, in cases in which there is a leukoplakia or a whitish patch and a histological diagnosis is required, and in cases in which the patients are aware of their dropping in the vocal pitch and they require pitch elevation as their main reason for treatment. Other symptoms may not necessarily be helped by surgery, and there is always the potential for making the voice worse by causing scarring or anterior webs or irregular edge of the vocal fold. When discussing the treatment options with the patient should be informed that his voice would seldom return back to normal after surgery, but it would generally have a better quality. Still, his friends and relatives may not be able to recognize his voice, say, over the phone, and that the singing voice may be permanently changed. Speaking may be more effortful for up to 1 year sometimes due to the increased stiffness following surgery. This can be permanent if there is excessive mucosal resection of the vocal folds or scarring of the vocal ligament or anterior web formation in the anterior commissure area. The Reinke's edema is likely to return within 2 years if the patient continues to smoke. Principles for surgical intervention in cases of Reinke's edema. First, confirm that the patient had stopped smoking. This can be all what is required, plus some voice therapy in cases of early or mild Reinke's edema. If the patient has not stopped smoking and continued to smoke after surgery, it's likely that the edema would recur within 2 years. The operation itself is meant to reduce and debulk the size of the subepithelial deposits in a way that would cause the least amount of disruption and induce the minimum amount of fibrosis and scarring in the subepithelial layer. The vocal ligament should remain completely intact. Any injury to the vocal ligament, either surgical or overheating by lasers, can induce permanent voice changes. And the trimming of the excess mucosa should be very careful because excessive trimming can lead to stiffness of the vocal fold. The old way of treating Reinke's edema by stripping of the vocal folds is now obsolete. Reduction glottoplasty, lateral cordotomy, or lateral microflaps, three names for almost the same procedure as first described by Herano almost 40 years ago. The surgery is started with an incision on the lateral part of the superior surface of the vocal fold. This can be done by laser sometimes or a sharp sickle knife. Then the submucosal layer is entered. This is the superficial part of the lamina propria. You can see the deposits in here. This should be dissected off the vocal ligament to avoid any injury to this whitish structure, the vocal ligament. Then the material in there, the deposits, can be aspirated, sucked out, or removed by cupped forceps, or sometimes vaporized by laser. Then the epithelium will be redraped over the vocal fold to see if there is any excess mucosa that should be trimmed. And once this is achieved, then some injection of steroids in the vocal fold would tend to help in healing without too much fibrosis, and also the vocal fold surface can be sprayed with lidocaine to decrease the chance of laryngeal spasm on extubation. Remember that extensive resection would lead to more than average fibrosis and may not provide good postoperative voice results. Postoperative period, advice should be given on voice rest, stressing that minimizing the phonation would reduce the stress on the surgical site and help with the healing. Smoking should be stopped by now. It's not clear whether proton pump inhibitors would have much an effect on the voice outcome after surgery. There is no much harm in trying it if the patient has gastroesophageal reflux symptoms. Oral steroids are not indicated unless there is a significant vocal folds swelling after surgery. Pain control with non-narcotic medications. The patient may experience some discomfort in the tongue due to the tongue compression with suspension laryngoscopy. This may require some painkillers and would usually settle with time. Good results can be obtained from just unilateral treatment of one of the vocal folds. And sometimes patients who are booked for stage procedures opt not to have the second vocal folds operated on because they are satisfied with the results after the first operation. Surgery on only a single vocal fold can reduce the vocal fold stiffening and decrease the chance of voice fatigue. By this, we come to the end of this presentation on Reinke's edema. Assalamu alaikum.